Hello students, I am Dr. Sowmiya, Assistant Professor, Department of Pediatric and Preventive Dentistry from Vinayaka Mission Shankaracharya Dental College. Today I am going to talk about vital pulp therapy. Mainly I am going to deal with indirect pulp capping and direct pulp capping and materials used. So first, pulp therapy. The treatment of deep caries that approximate the pulp chamber, whether the dental pulp should be preserved to maintain the vitality or completely removed or to prevent the necrosis, infection and induction of apical periodontitis. The main goal of pulp therapy, according to Mathewson, is to maintain the arch length and tooth space because the primary teeth acts as a space maintainer, natural space maintainer. The restoration of comfort with the ability to chew because once the tooth is there only, the patient can able to chew. Next, to prevent the speech abnormalities and abnormal habits. Coming to vital pulp therapy. Vital pulp therapy is designed to preserve and maintain pulpal health in teeth that have been exposed due to trauma, caries or restorative procedures or maybe due to anatomic anomalies. So this vital pulp therapy is broadly classified into indirect pulp capping, direct pulp capping, pulpotomy and apexogenesis. First we are going to see about the indirect pulp capping. So the important definition of indirect pulp capping is given by the AAPD in the year 2020. So it states that indirect pulp treatment is a procedure that leaves the deepest caries adjacent to the pulp undisturbed in an effort to avoid a pulp exposure. The caries affected dentin is covered with a biocompatible material to produce a biological seal. So the other name of this indirect pulp capping is rest treatment. This term is very important, and then the objectives of this indirect pulp capping is to maintain the pulp vitality while arresting the caries process, promoting the dentin sclerosis, stimulate the formation of tertiary dentin or reparative dentin, remineralization of the carious dentin, maintenance of normal healthy pulp. So the rationale of this treatment is very few viable bacteria which may remain deep into the dentin layers, and after the cavity has been sealed properly, it will be inactivated. Coming to indication, deep asymptomatic lesions that in radiographically it is close but not involving the pulp in primary or young permanent teeth. Rampant caries or nursing bottle syndrome tooth. No extreme pain must be associated with only eating, and contraindications according to Kennedy are spontaneous pain, mainly pain during night, swelling, fistula, tenderness on percussion, pathological mobility, external root resorption, internal root resorption, periapical or interradicular radiolucency and pulp calcification. Coming to the advantages. So the arrest and at least it slow down the decay process. In the bacterial count of the mouth is markedly reduced. Mouth can be restored to the function so the patient can be able to eat and speak properly. Threat of the dental pain is reduced and also removed. Pulp exposure is also avoided. So importance of this treatment is firstly based on the case selection. So first case, under case selection, the first is pain history. Pain should not be more than 20 minutes after the food intake, and there should be no nocturnal pain. Next, coming to the clinical examination, there may be no marked gingival pathologic condition, no mobility of the tooth, and there may be a large caries lesion. Coming to the radiographic examination, there might be a probable caries exposure, but not only the approximation of the caries to the pulp should be seen, but not on the pulpal chamber. So normal periapical and furcation tissues must be seen. Coming to the procedure, first it can be done under two sittings, can be done in a first sitting or in a two sittings. So first sitting, administer LA, we have to isolate the tooth with rubber dam, remove all unsupported enamel structures, slowly remove the carious dentin using slow speed burr or a hand and spoon excavator, apply Dicel over the cavity and then place IRM or ZOE using an amalgam plunger or a plastic instrument. Then we can remove the excess Dicel on the walls and then we can give the final restoration and a stainless steel crown. If this treatment can be carried out in one step, we can do all this in a first appointment itself. When we have to go for a second appointment, it have to be carried after 6 to 8 weeks. We have to again put a LA and we have to isolate the tooth with rubber dam, remove the provisional restoration which was given on the first appointment, remove any carious lesion that have been left in the first appointment and replace the Dicel, and final restoration can be given. Over that the stainless steel can be provided. So coming to the materials used for the indirect pulp capping, there are calcium hydroxide, mineral trioxide aggregate, that is often called as MTA, biodentin, zinc oxide eugenol, bone morphogenic proteins, corticosteroids and antibiotics, resin-modified glass ionomer cement, isobutyl cyanoacrylate, and newer materials such as odontogenic amyloblast-associated protein, teracalc, and enzymes such as heme oxygenase and simvastatin. Coming to the definition of the direct pulp capping. According to AAPD in 2025, when a pinpoint exposure at least 1 mm or less of the pulp is encountered during the cavity preparation or following a traumatic injury, a biocompatible radio-opaque base such as MTA or calcium hydroxide may be placed in contact with the exposed pulp. The tooth is restored with the material that seals the tooth from the micro leakage. Coming to the objectives, we have to seal the tooth against the bacterial leakage, and that is a new dentin formation on the exposed pulp area. The healing of the pulp will happen and maintain the vitality of the pulp. The rationale of this treatment is to achieve a biological closure of the exposure site by deposition of the hard tissue barrier, that is dentin bridge, between the pulp tissue and the capping material, thus walling off the exposure site. Coming to the indication, there may be a small mechanical pinpoint exposure which is less than 1 square millimeter surrounded by the dentin. It should be asymptomatic vital primary teeth or young permanent teeth. Bleeding should be bright red in color, which can be easily controlled using a cotton pressure, which we have to apply for 1 to 10 minutes. There might be absence of pain and discomfort only taking the food. The contraindications are severe toothache at night, spontaneous pain, tooth mobility, radiographic appearance of the pulp and periradicular degeneration, excess hemorrhage at the point of exposure, serous exudate from the exposure, external or internal root resorption, and swelling or fistula. So coming to the treatment consideration, again case selection is very important. There might be a pinpoint pulp exposure which is less than 1 millimeter can be capped. So the exposure can be iatrogenic or traumatic insult, the tooth with minimal or no pulpal inflammation. We have to debride the caries, so we have to excavate only the peripheral mass of the infected or necrotic pulp dentin chips and never at the exposure site. So how we control the hemorrhage and clotting? So quality of bleeding at the exposure site is very important. There must be no profuse bleeding. The bleeding should be bright in red, controlled using a moist cotton pellet. Irrigate every 3 to 4 minutes with using a normal saline, sodium hypochlorite, etc. Remove any clot formed over the exposed pulp surface because this clot contains the bacteria which may lead to the bacterial proliferation which hinders in the pulpal healing. Coming to the technique. First, again rubber dam isolation is very important. Once exposure is encountered, further manipulation of the pulp is avoided. Irrigate the cavity with a sterile cotton pellet. Arrest the hemorrhage with a slight digital pressure. Place of pulp capping material. Placement over that placement of temporary restoration. Final restoration should be given after the formation of dentinal bridge and lack of pain. So then the final restoration should have the good marginal C. Materials used for direct pulp capping are calcium hydroxide, zinc oxide eugenol, formocrazole, mineral triaxide aggregate, that is your MTA, biodentin, corticosteroids, isobutyl cyanoacrylate, denatured albumin, dentin bonding adhesive, enamel matrix derivatives. We will see about the calcium hydroxide. It was first introduced by Hyman in 1930 to the dentistry. So it induces the bridge of the exposed pulp with a reparative dentin. So this calcium hydroxide is a white crystalline, slightly soluble basic salt that dissolves into calcium and hydroxyl ion in solution and exhibits a high alkalinity. So the said cement has a high pH of 11. This is commercially available in the name of Dical, Pulpdent and Hydrax. Coming to the mechanism of action, so this calcium hydroxide is divided into calcium and hydroxyl ion. This hydroxyl ion neutralizes, due to its high pH, it neutralizes the acid produced by the osteoclast, which acts as an optimum pH for the pyrophosphatase activities. So there may be an increased level of calcium ion dependent pyrophosphatase. This pyrophosphate is responsible for the inhibition of the mineralization of the tooth. So this calcium ion independent pyrophosphate combined with the calcium which is removed from the calcium hydroxide cement causes the reduced capillary permeability, which also reduces the serum flow and reduces the level of inhibitory pyrophosphatase, thereby mineralization occurs. So what is the mechanism for antibacterial effect? So hydroxyl ion is a purely responsible for this antimicrobial effect. So it destroys the phospholipids of the bacterial cell membrane, and it destroys the bacterial cell membrane. The high alkalinity breaks down the ionic bond so that the bacterial proteins are denatured, and it also reacts with the bacterial DNA. Thereby it destroys the bacteria. So according to Glass and Sander in 1949, they stated that calcium hydroxide directly on contact with the pulp causes necrosis, and after 24 hours separated from the healthy tissue. So 14 days later, the partly calcified fibrous tissue lined by the osteoblast, and after 28 days, the zone of new dentin formation was evident. So the concentration of the hydroxyl ion was considered to be the responsible of these initial tissue changes. Thereby the high pH and low solubility prolongs the antibacterial effect. Coming to the tunnel effect, this calcium hydroxide has one effect known as tunnel effect. It is very important to know that, because calcium hydroxide products are absorbable over a period of time, and it is dimensionally unstable. So the slow disintegration of the calcium hydroxide after a hard tissue barrier formation can allow the micro leakage into the pulpal tissues. So there may be a slow ingression of a microorganism through the calcific barriers, and then subsequent pulpal degeneration, followed by the further leading to potential dystrophic calcification and pulpal necrosis. So the advantages of this calcium hydroxide is it's bactericidal to bacteriostatic, it promotes the healing and repair, high pH, and it stimulates the fibroblast, inexpensive and easy to use. But the disadvantages: primary teeth may cause internal resorption, as you see in the tunnel effect after 1 year of placement, and it does not adhere to the vital dentin. So the known commercial product is Dical. It was introduced in the year 1962 by LD Chalk Company. It's a two-phase system. The base phase consists of titanium dioxide in glycol silicate and pigment, and the catalyst phase consists of calcium hydroxide, zinc oxide in ethyl toluidine sulfonamide. The pH of the set cement is 7. Compressive strength of the set cement is 1100 psi, and it can be used as a sole base medium. Coming to the zinc oxide eugenol. It is available as a powder and liquid. The powder consists of uncalcified zinc oxide plus small amount of zinc stearate and zinc acetate and rosin. The liquid consists of purified eugenol, or in some cases with oils of clove. And Sween in 1969 stated that 87% of success rate with the capping material of primary teeth with zinc oxide eugenol in an ideal situation of a pulp exposure. Tronson and Major stated that zinc oxide eugenol is more beneficial for inflamed and exposed pulp. But there are many studies stated that it is not suitable to use zinc oxide eugenol as a pulp capping agent. So they stated that zinc oxide eugenol on direct contact with the pulp can cause chronic inflammation and abscess, liquefaction, necrosis on the pulp. There is no calcific bridges was evident, and it could not find any positive recommendation for the using of this zinc oxide eugenol on the direct pulp capping. Coming to the formocrozole. Formocrozole, when it is mixed with the zinc oxide eugenol on the exposed vital permanent teeth, it does not cause any dentin bridge formation. So the histological study stated that increased inflammatory cell infiltrates, zone of atrophy was seen, and absence of tertiary dentin formation, thus making it unsuitable for using the direct pulp capping agent. So coming to mineral trioxide aggregate, is so called as MTA. It was reduced by Mohammed Torabinajit in 1993. It was developed at the Loma Linda University, California. The composition of this MTA is tricalcium silicate, dicalcium silicate, tricalcium aluminate and bismuth oxide. The MTA has two types, that is grey MTA and white MTA. In this, the grey MTA has the tetracalcium aluminoferrate, which is grey in color. So this causes the color change in the MTA. So MTA may also contains the trace of free crystalline silica, trace constituents such as calcium oxide, free magnesium oxide, potassium and sodium sulfate components. The physical property of MTA is compressive strength of MTA is 70 megapascals. The pH is initially 10.2, which rises to 12.5. It has a high sealing ability with a low micro leakage. The thickness is of 3 to 5 mm is sufficient to provide a good seal. Coming to the antibacterial efficacy, it is against M. luteus, S. aureus, E. coli and P. aeruginosa, etc. So it has the high regenerative potential and biologic activity, and also capacity to induce bone, dentin and cementum formation, and also regeneration of the periapical tissues. The radio opacity is 7.17 mm. Coming to the setting reaction, when MTA on hydration, it converts into calcium silicate hydrogel and calcium hydroxide. This calcium hydroxide causes the increase in the pH to 12.5. This calcium hydroxide acts same as that of the calcium hydroxide which was seen earlier. So this calcium silicate gels forms a porous cell which solidifies to form a hard crystalline structure. So it is advocated that the powder liquid ratio is of 3:1. The mixing can be done on paper pad or on the glass slab using a plastic or metal spatula to achieve a putty-like paste consistency. This mixture should be covered with a moistened cotton pellet to prevent the dehydration of the mix. The mechanism of action of MTA is MTA proliferates the pulpal cells. It stimulates the osteoblast to increase the interleukins with formation of hard tissue. The new dentin bridge that is formed is of thickness and hardness which is far higher than it was formed by using the calcium hydroxide. The advantages of MTA is it causes the dentin bridge which is superior in structural integrity, superior ability to resist the future penetration of the bacteria than calcium hydroxide, high biocompatible with pulpal and periodontal tissues. Pulpal tissue shows negligible necrosis with minimal inflammatory reaction. It is a hydrophilic material, so it sets hard in the presence of water also. The set MTA is of alkaline, that is 12.5 pH, may induce the dentinogenesis. The disadvantages of MTA is it has a long setting time, 2 hours 45 minutes, which mandates the two-step of capping procedure. It is difficult to manipulate, expensive material, and it both grey and the white MTA stains the tooth to grey color. Coming to the biodentin, it was introduced at 2009 as a specifically designed as a dentin replacement material. This is very important. It works as a dentin replacement. So it is also a calcium silicate based material. It also contains a powder and liquid. The powder consists of tricalcium silicate, dicalcium silicate, calcium carbonate, zirconium oxide and iron oxide. The liquid consists of calcium chloride which acts as a setting accelerator, hydrosorbable polymer. The mechanism of action of biodentin is the material induces the odontoblast like the cell differentiation. It stimulates the biomineralization and promotes the hard tissue formation when used as a pulp capping material. Coming to the setting reaction, in capsule, powder and liquid is dispensable. It can be triturate for 30 seconds. Hydration of the tricalcium silicate will happen. This hydrated calcium silicate gel and the calcium hydroxide will form the set mass. The unreacted tricalcium silicate grains are surrounded by the layers of a calcium silicate hydrated gel. So it is relatively impermeable to water, thereby slow down the effects of further reactions. It sets approximately in 10 minutes. Coming to the advantage, it's used for the pulp capping material and also used to bulk fill the cavity. It does not stain the tooth as that of MTA. It has excellent radio opacity, high compressive strength than dentin and preserves the pulp and also promotes the pulpal healing. The microbe leakage resistance is enhanced by the absence of shrinkage due to the resin-free formula. The last thing we are going to see is the limitation of pulp capping in primary teeth. So the primary pulp consists of high cellular content and abundant bed supply, which is responsible for more rapidly to the effect of dentin caries than the permanent teeth. So the poor localization of infection and faster inflammatory response lead to the internal resorption of the primary tooth. So the pulp capping materials, it have to stimulate the undifferentiated mesenchymal cells to osteoblast. Instead of that, due to the high cellular content and abundant blood supply, the undifferentiated mesenchymal cells have differentiated into the odontoclast cells. So this causes the resorption. Thereby, it leads to the failure of the treatment. So, direct pulp capping is contraindicated in the primary teeth. Thank you for watching my class. Thank you all.